We would like to thank Amgen for providing an unrestricted grant to support the IACH webinar series.
Hi everyone, thank you so much for joining me. My name is Amer Zeidan. I'm an associate professor of medicine at Yale University. I lead the leukemia and myeloid disease research team and direct the hematology early therapeutics research. It's a pleasure to go over highlights of the American Society of Hematology 2021 meeting focused on new developments for MDS, in particular higher risk MDS, where the focus of my talk will be today. This is my email, this is my Twitter handle. Please feel free to reach out if you have any questions. So I chose the most important, in my view, some of the most important clinical highlights of MDS. Of course, ASH is full of great presentations and many great studies. However, it's very difficult to try to summarize all of this in the limited time that we have today. So apologies to anybody who I did not select their presentation. Also, the format is going to be going through the different studies over 30-35 minutes, and then we'll have 5 to 10 minutes at the end for any questions. So these are my disclosures. And most of the presentations I'm going to cover today are looking at therapeutics. However, there was, I think, one clinically relevant presentation in terms of daily clinical practice that was on the prognostication front that I think is important to highlight. So many of you are familiar that in MDS, there are a number of prognostic scoring tools that we use. Because MDS, unlike some other cancers, prognosis can vary significantly, all the way from having a prognosis similar like acute myeloid leukemia, where survival can be a few months, all the way to patients who can live 10, 20 years with minimal disruption to their life. So you can see in this slide some of the most commonly used prognostic scoring systems. The IPSS and the revised IPSS are the most common ones. However, one of the problems with most of these prognostic tools is that they do not incorporate the molecular alterations that we have known for several years now that they affect the prognosis of MDS patients. And there has been several attempts at incorporating molecular alterations into prognostic scores that we use on day-to-day. You can see to the left of, to the right of this slide, some of those systems, the EuroMDS and the MDS Clinical Research Consortium scoring tools that incorporated molecular data. But the one that was presented in this American Society of Hematology meeting is one prognostic tool that we've been waiting for actually for multiple years, because this is the molecular IPSS. So the revised IPSS has been basically adjusted to include molecular alterations, and the model you can see here was fed through a robust Cox multivariable regression model adjusted for confounder variables. So some of the highlights that this molecular IPSS has is that it still uses the bone marrow blasts, which we have always used, the platelet count and the hemoglobin, all of which are part of the revised IPSS. However, it does not account for the neutrophil count, which was a component of the revised IPSS, because it was shown not to be significantly independent when you account for the other variables. It also maintains the cytogenetic categories the same way we've been doing them in the revised IPSS, the 5 groups. And then, as you can see in the bottom, it adds data from 31 genes. So 31 genes basically that have been shown to affect the prognosis of patients with MDS. And you can see here that the final result is that the patient would be classified in one of 6 categories. So instead of 5 categories like it was in the revised IPSS, now we have 6 groups. You can see very low, moderate, high, and very high. And you can see on the Kaplan-Meier figures that the leukemia-free survival and overall survival can differ significantly between these patients. So how would that work clinically? Basically, you will have a calculator, because of course this is very difficult to do by hand because you have 31 genes that you need to enter. And you can see a picture on the left side how that calculator will look, where you enter for each particular gene, you enter whether it's mutated or not mutated, and you enter the other variables that we discussed, and then you get a result that looks like the right side of the screen, where it gives you the revised IPSS molecular score in terms of which group, and also it gives you the regular revised IPSS and the adjusted revised IPSS. In the bottom, you can see that sometimes, depending on where you practice, you might not have all these genes results back to you. So if you have missing genes, you can enter them as missing, and then you get a range of a score rather than one specific score. So this basically, I think, is important development. However, this WIP calculator, the last I checked, is still not publicly available. And as many of you know, it's not easy always to get all these molecular results back in time when you are trying to make decisions on the patient. But also, most importantly, not every center does all these different genes. So I think how does that play out in practice is something that we will have to watch out carefully. Now moving gears to the therapeutic abstracts, which are the bulk of this talk. So this is a presentation on the use of oral decitabine sidazolidine in the Ascertain trial. This has been previously presented by Dr. Savona last year, ASH, or in 2020 ASH, basically, where patients who were intermediate 1 and higher with MDS basically were enrolled on this trial. Patients were randomized to receive the IV formulation of decitabine versus the oral decitabine sidazolidine. And the idea is that sidazolidine inhibits cytidine deaminase and therefore allows the absorption of decitabine in bioavailability equivalent kinetics. However, after one cycle, if the patient started on IV, they crossed over to oral, or if they started on oral, they crossed over to IV. And then starting the third cycle, everybody continued on the oral formulation. So you cannot really compare clinical outcomes between IV and oral. The endpoint was pharmacokinetic equivalence. However, when you look at the entire group of patients who went into the study, the complete response rate was 22%. The durability was 12.7 months. So that's somewhat in line of what we see with IV decitabine. So I think it's fair to say that the clinical activity is similar. What was presented in this ASH meeting, in 2021 meeting, is an update in lower risk MDS patients. As I mentioned, patients who had intermediate 1 technically on the revised IPS or on the IPSS are considered lower risk MDS patients. So those patients were analyzed specifically to see their responses. And you can see that the CR rate among those patients, who were 69 out of the entire group of patients, the CR rate was 27%. Marrow CR was observed in 42%. The responses were durable, 15 months, and the median time to first response was 3 months, and to best response was 4 months. For transfusion independence, and I think this is very important, for patients who were transfusion dependent at baseline for red blood cell, around 50% became transfusion independent, and for platelets, the number is quite small. It's only 6 patients who are transfusion dependent. However, 68% became transfusion dependent. So I think this basically highlights that this oral combination also certainly has the potential of resulting in transfusion independence for patients who are needing blood transfusions and has activity in lower risk MDS. The question becomes regarding the dose. As many of you know that with decitabine and azacitidine, there are trials that showed using shorter courses, 3 days of decitabine, for example, rather than 5, might be sufficient for those patients. So there's currently a separate trial looking at this drug CDIC or Aztec 727 in patients with lower risk MDS that tests different doses of the drug at the standard dose, which is 5 days, or at a short or different courses, shorter doses. Moving to the combinations which have been at the front of MDS management, similar to AML treatment. So azacitidine and venetoclax is one combination that has attracted a lot of attention. Venetoclax is a PCL2 inhibitor. Basically, what PCL2 does is that sequesters pro-apoptotic factors. Therefore, prevents the death of cancer cells. What cancer cells, including MDS and AML, do is that they increase the expression of BCL2 so that they are less likely to die and undergo apoptosis. When you use venetoclax, it physically fills in, it physically goes to the BCL2 and displaces the pro-apoptotic factors, which will go to the mitochondria and initiate apoptosis. And increased BCL2 expression has been shown to be a mechanism of resistance to azacitidine, as you can see in the lower part of the slide. Combining azacitidine and venetoclax in AML has been shown to be synergistic and clinically has been approved in the frontline treatment for older unfit patients. And you can see preclinical data in the frontline and in the refractory relapse setting in the right upper hand side of the slide, showing activity of the combination. So based on this preclinical data, the combination was taken to clinical trial testing, and those are results from the phase 1 study. This has been presented more than once, and an update was provided in ASH meeting 2021, where patients with MDS were basically treated with a combination azacitidine given at the standard dose for 7 days. Venetoclax, important to note, was given at 3 different dose levels, 100, 200, and 400, however, only for 14 days. So it was not continuous administration similar to AML. And that's important to note. This analysis focused on the patients who were treated at the phase 2 dose level, which is the 400 milligram given on day 1 to day 14. So that's 51 patients. You can see the responses were 84% overall. Complete response was 35%. And you can see that the duration of response was actually quite good at 12 months. To the right, you can see that the mutation spectrum that was seen in those patients, and that responses occurred across the entire spectrum of patients with MDS. So even including some patients with TP53 mutations. And on the safety front, I'm not showing you the slide, but we've already seen from previous presentations that infectious complications and cytopenias were the main complications that can happen with this regimen. It's very important to monitor these patients carefully, monitor for drug interactions, and transfuse them as needed, because those can lead to complications. You can see here the swimmer's plot showing the durability of response of the combination. So I think this trial is very, very important in terms of understanding where venetoclax role in the front line use. However, it's a small study. It's only 50 patients at the ideal dose and a single arm study. So currently there is the ongoing randomized phase 3 trial, the Verona trial, which looks at azacitidine with placebo versus azacitidine with venetoclax in high risk MDS. And I think this will provide the definitive answer about the use of this combination in the future. This trial is currently ongoing and accruing. In the refractory relapse setting, I presented on behalf of our co-authors an update of the phase 1b study. This is a similar study to the one I just showed you. However, it was only in the refractory relapse setting. And you can see here we had a similar dose escalation and dose expansion. And the data you are seeing here right now, it's in the combination of venetoclax and azacitidine in the in this patient sample. You can see the baseline characteristics are very classic for refractory relapsed MDS. Median age is 74. Most of those patients have more than 5% blast. Most of them have high level of cytopenias and transfusion independence, and all of them are heavily pretreated. You can see that the median number of HMA cycles was 9 cycles. So most of those patients have received a lot of azacitidine or decitabine. Safety data is along the lines of what I showed you in the frontline setting. High incidence of cytopenias as well as infectious complications with febrile neutropenia, 34%. However, those were managed by antibiotic prophylaxis, management of infections, treatment discontinuation when needed. And while many patients basically had grade 3 adverse events, you can see that only 3 patients died within the first 60 days of the study. and that was only 7%. However, most of the deaths that occurred on this trial were related to disease progression and not related to treatment. When you look at the durability of these CRs, the CR rate was 7%, but the overall response rate was 39%. So the 32% were marrow CRs. However, more than half of these were associated with hematologic improvement, so clinically meaningful marrow CRs. You can see that durability was median duration was 8.6 months, and around half of the patients, 43%, were in remission at the time of or at 1 year after the starting the treatment. Here you can see that the responses were observed across the mutational spectrum, including some patients with TP53, the most difficult, to treat disease subset, and also transfusion independence, which is a very important endpoint in my view for any kind of myeloid malignancy, but in particular refractory relapsed MDS. You can see that close to 30% of patients who were transfusion dependent at baseline became transfusion independent in the context of the follow-up of this study. And 43% of patients who achieved marrow CR had hematologic improvement with it. The overall survival was also encouraging. The median OS on this study was 12.6 months. Historically, the median OS after HMA failure is around 6 months. So again, very difficult to do comparisons to historical control, but the survival signal is encouraging. And that was also seen when you segment the patient by the IPSS, revised IPSS, was seen basically among patients with high and very high revised IPSS and patients who have more than 5% blast as well. So overall, again, I think very encouraging data in the refractory relapse setting. In this ASH also, there were some presentations about real-life analysis of azacitidine in the community or outside of the clinical trial setting. And in this presentation from the Moffitt group, you can see patients have received venetoclax, and that's again because venetoclax is available for AML, so off-label use is happening in the community. And here they wanted to report on the real-life outcomes. And you can see here that in the frontline setting, the response rate among 35 patients who received the drug in the frontline setting was 44% CR and overall response rate 87%. The median OS was 21 months. So actually somewhat similar to what was seen in the clinical trial that I showed you earlier. I think what was also impressive in my view is the activity in the relapse refractory setting. So they have patients, basically 31 patients who received HMA-VIN for refractory relapse disease. And those, again, were heavily pretreated. The median number of cycles was 6 cycles, so it's not like they've gotten 2-3 cycles. But the overall response rate, CR was 13%, marrow CR was 48%. So this is confirming activity by adding venetoclax. So, and some patients who were able to proceed to transplant also have achieved prolonged survival. So I think when you take all this data together, it's clear that there is some activity. The question is how much activity compared to other interventions, and this is what the randomized trials are going to answer for us in the frontline setting. In terms of oral combinations, and I think this is a very exciting venue that is being also studied, double oral or total oral therapy. Here, the study looked at adding venetoclax with oral decitabine, the 727, Aztec 727, or CDEC agent I mentioned to you earlier. So this was a presentation in patients who were HMA naive, so frontline treated patients. Again, 9 patients only were treated. And you can see the CR rate or the overall response rate was quite high. So that's certainly encouraging. However, the CR rate by itself was on slightly lower than what we just seen with AZA alone. However, it's important to note that all of these patients have very deep neutropenia. So the ANC has dropped. So management of infection, prophylaxis, drug interactions are very important. And I would discourage people from trying this combination of label. CDIC is available as monotherapy for higher risk MDS. It's approved in the US. But I would not try this double oral therapy until we have more clinical trial data. I mentioned the Verona trial, which we presented previously in the American Society of Hematology, and in the ASCO meeting, looking at the design of this trial where patients are being randomized one-to-one of AZA versus AZA-VEN, and I think this trial is going to be very important to understand where venetoclax will land in the management of MDS. Now to a less exciting development, which is pivonidistat. So pivonidistat is a NID8 activating enzyme inhibitor. This is a first-in-class agent, basically, that generated a lot of excitement early on because the early results in AML and MDS in combination with azacitidine were promising. Here you can see results that were presented, not this ASH, the prior ASH in 2020, from a randomized phase 2 study looking at AZA versus AZA with pivonidistat. And you can see to the right the impressive clinical results from this study, which showed a complete response rate of 50% with the combination, and the durability, which was quite impressive with this combination, was 3 times the durability of response with azacitidine alone. However, the EFS, event-free survival, which was the primary endpoint of this study, was marginally better. You can see the p-value was 0.045. So a phase 3 trial was conducted called the Panther. It's a phase 3 of pivonidistat plus AZA versus alone in patients who had MDS, oligoplastic AML, or CMML. And it's the same design as the trial I just showed you, the randomized phase 2. Azacitidine was given at the standard dose. And you can see here the baseline characteristics of patients who were enrolled. Close to 450 patients were enrolled on this study, around 160 patients in each arm with MDS. So the results were surprising and disappointing at the same time. So on the response front, you can see, especially for the entire intention to treat population for the overall study, the CR rate for the combination versus AZA were not that different. Actually, it appears that azacitidine had a higher CR rate, 31% compared to 28%, and the same for overall response rate. When you look specifically at high-risk MDS, the CR rate with azacitidine alone was higher than the combo, 32% versus 24%. And when you look at median EFS and OS, as you can see here, there was also no difference. The median event-free survival, 17 months with the combo versus 15.7 months with AZA, and similarly, no statistically significant difference in overall survival. So overall, this study was negative, and pivonidistat, which was showing promising data early on, I think now doesn't have a very clear path in the frontline setting of MDS. Moving from pivonidistat to a class of agents that I do myself quite a bit of clinical research on and translational work, as well as both in AML and MDS, which are immune checkpoint inhibitors. So many of you, especially those who work in solid tumors, are probably familiar with some of the immune checkpoint inhibitors that are currently in practice. PD-1, PD-L1, CTLA-4 have made significant progress for solid tumors, and we are trying to explore this in patients with MDS. We have conducted, and we just published, this just came online for those of you who are interested to read the paper in Blood Advances. We published the first randomized trial of immune checkpoint blockade in higher risk MDS with AZA versus AZA with durvalumab, which is an anti-PD-L1 inhibitor. You can see that there was no difference in overall response rate. There was no difference in progression-free survival or overall survival. So this trial was negative. However, I think this applies to the PD-L1 class, because we've seen similar data with Dorva and atezolizumab. However, there is more exciting early phase data with PD-1 with CTLA-4, as well as some of the novel immune checkpoint inhibitors. One of them is sabatolimab or MPG453. This drug targets a novel immune checkpoint receptor called TIM3. So TIM3 is not only expressed on T cells and innate and adaptive immune system, but also on some of the innate immune system cells such as macrophages and monocytes, as well as NK cells. But also importantly, it's expressed on leukemia stem cells and blasts, but not on the normal hematopoietic stem cells. Therefore, it's dual targeting by immune system activation, but also by directly targeting the leukemia stem cells. And MPG453 or sabatolimab is a humanized IgG4 antibody against TIM3 that was shown in preclinical models to disrupt the leukemia stem cell signaling, but also to cause immune activation and immune cell mediated killing of leukemia stem cells and blasts. So this was taken to a phase 1 trial. This was presented also multiple times in ASH and other meetings of combining the cytidine or azacitidine with sabatolimab. And this is the latest presentation by Dr. Bruner in ASH 2021. You can see here the baseline characteristics of the patients. I'm focusing here on the MDS cohort. So there were also patients with AML. Among the 53 patients with MDS, you can see the median age was 70. Most of those patients had high or very high IPSS risk, and TP53 mutation was present in 15 out of 42 patients with high-risk MDS. You can see to the right, I think importantly with sabatolimab, you can see the incidence of adverse events as classified by grading in this tornado plot. Of course, here it's a single arm study. We don't have a comparison of azacitidine alone, but the side effects you see are very classical for azacitidine and not that different, mostly GI stuff as well as count suppressions. Importantly, the immune-related adverse events with this drug in particular, they don't seem to be as common or as severe as we see them with other immune checkpoint inhibitors, which I think is important from a point of view of tolerability, given that many patients with MDS are older and more frail. Clinically, you can see here the results of this study. You can see that the response rate, again, single arm study, but the overall response rate was 57%. The CR rate was 20%. However, I think the most notable finding in this study was the durability of responses, which seem to be better. Again, we don't have a direct control arm, but historically than azacitidine. But specifically, when you look at patients who have adverse risk or those with TP53, as you can see here, those patients are in particular have very durable responses. So the denominator is small, only 14 patients, but 10 of them, 70% had an overall response rate and durable responses of 21 months. So I think we are seeing some encouraging signal on the safety, on the durability, although the overall response rate does not seem much higher, at least overall. So based on all of this data, a number of randomized trials have been initiated. And in ASH 2021, for those of you who are interested in the details of those trials, we have presented the data basically of not presented, I guess, discussed the design of these trials. Stimulus MDS1, which is a randomized phase 2 trial. Sorry, this is a typo says phase 3. It's a randomized phase 2 trial that actually fully accrued. 127 patients have been randomized, and we are waiting for the results of this trial. But there is also an ongoing randomized phase 3 trial of sabatolimab with AZA versus AZA with placebo. That's ongoing, 500 patients. And then the Stimulus MDS US trial that is adding sabatolimab to any HMA, including oral HMA. And lastly, an ongoing study of azaven with sabatolimab. So a very extensive program of development, and I think we will have some answers over the next couple of years about the activity of sabatolimab in MDS. Moving gears to another drug called APR-246 or ibrinitopop. This is a drug that targets TP53, which is a very difficult area of unmet clinical need in MDS. So this drug can cause refolding of the TP53 so that it becomes functional again. What was presented in ASH 2021 is an update of the phase 2 trials. So there were 2 phase 2 trials that were published both in JCO. Here they did a combined analysis of those 2 trials, one from the US and one from France, and showed that the CR rate was, again, the findings are really not that different from the 2 studies. The CR rate was around 40%. The overall survival was around 11.8 months. So for TP53 mutated MDS, that's actually good. However, I think the most important thing to remember is that there's a phase 3 trial that was press released of APR with AZA versus AZA alone that did not meet the primary endpoint, which was improvement in complete remission rate. So I think that's something we are waiting for to get to see the results of this trial presented. And until then, the future of this drug is still not very clear in MDS. IDH1 and IDH2 are 2 drugs that are approved in AML, in refractory and relapse AML. Here in MDS, these mutations are seen, but they are not as frequent. They are around 5 to 10% for these mutations. So we have 2 trials presented from the French group, the GFM group, one called the IDEAL trial of inacidnib in IDH2 mutated MDS, and the other one I'm show you later in IDH1 mutated MDS. You can see multiple cohorts, 3 cohorts in this trial, small number of patients. It included adding inacidnib to HMA for those who had HMA failure or using combo. Overall, basically, you can see the dosing was 100 milligram, which is similar to the approved dose of inacidnib in this setting. And you can see, again, I think it's very tough to make too much of the specific percentages because of the small numbers. But overall, there were 23% complete response rate in this setting. So clearly indicating activity. Similarly with ivosidenib in the IDH1 setting, a similar design study called the Idiom Study for IDH1 mutated MDS. Again, 3 cohorts, small number of patients. You can see here the specifics of each cohort. Ivosidenib was used at the same dose that's approved in clinical for AML in the US for IDH1 mutated AML, which is 500 milligram daily. And you can see here also the response rate, the overall response rate in the different cohorts. Again, small numbers, but it's clear that there is significant activity. So I think because of this data and other data presented by the US groups, it's clear that there is activity with IDH inhibitors, and it's something that I actually do off-label in some of my patients by looking at their responses in the frontline, in the relapse setting, not as a frontline option, but someone who progresses on HMA and I have no clinical trial. If they have an IDH1 or 2 mutation, I try to use that off-label, but have to remember you have to monitor the patient for differentiation syndrome, which can happen and can be severe. So it's very important to consider that when you start IDH inhibitors in MDS patients. Lastly, the last 2 abstracts I want to highlight in the last couple of minutes are looking at CPX351 or liposomal vincristine daunorubicin, which is, as you know, approved in the US for treatment of therapy-related and secondary AML based on data, randomized data showing activity in patients who with this type of AML who are 60 to 75. However, there was a lot of interest in studying this in MDS as well, so patients who are not with AML. So 2 studies presented, one from the GFM French group, 12 centers. The primary endpoint was response to induction treatment. You can see here that the patient had to have intermediate or high IPSS, and they had to be younger, so they are less than 70. So those are patients who are candidates for intensive chemotherapy. Again, remember, this is intensive chemo, so it's something you have to think about when you are giving to MDS patients who are typically older and frail and have comorbidities. And you can see again that most of those patients, median age is 60, much younger than your typical MDS patient. And importantly, 70% had good risk karyotype, 7% have very good. So almost 77% of patients have very good or good karyotypes. So those are not your typical complex karyotype or poor risk cytogenetics. And that's very important to remember when you look at the response rate you can see in this slide. So the response rate, overall response rate was 87%. The CR rate you can see here, when you look using the IWG criteria, 2006, 23%, but when you look at the ELN criteria, which are AML criteria, is 52%. Some of those patients have undergone consolidation. Some of them have, you can see almost 29 out of 31 went to transplant, which is highly unprecedented in my view in MDS studies. Again, telling you how good of a shape these patients who went in this treatment were on. So encouraging results, small study, single arm, very healthy patients that don't really represent the real MDS patients in the community. So it could be an option, but again, I think that's something that has to be individualized in the off-label use. This is the CPX 351 study. So it's a similar study like the US study, like the French study, has enrolled a small number of patients, 20 patients you can see here. Again, younger patients, median age 62, intensive chemo candidates, most of them high or very high risk. And you can see only 2 patients out of the 20 had TP53. Those are patients who typically, I think many of us feel, don't benefit very well from CPX management. So important to note in both of those studies, similar to intensive chemo, high incidence of infectious complications. Most patients have febrile neutropenia. Some patients have sepsis. So those patients have to be monitored. And again, this is intensive chemo treatment. The dose that was chosen is actually the dose that's clinically used for AML. The response rate, the CR rate was 20%. And most of the marrow CRs, 60%, some of them were associated with hematologic improvement, and many patients proceeded to allogenic bone marrow transplant. So again, both of those studies indicate it's feasible. However, highly selected patients, younger, without many comorbidities, in which you are trying to get the patient to a transplant, which does not apply, I think, in the vast majority of MDS patients, and also a significant toxicity profile. So those patients have to be monitored and managed very aggressively. So in summary, a large number of clinical trials are going right now for MDS. You can see here that we are going to the precision medicine or individualized treatment. We are choosing therapies more based on alterations, IDH1, IDH2, FLT3, but also doing trials, for example, MEK inhibitors for RAS mutated patients, TP53 patients. I did not talk about magrolimab, the anti-CD47, because there was no update in this ASH meeting. And we did not talk about lower risk MDS, but there's also a large number of trials that are ongoing in the lower risk MDS space. So at the end, I like to thank the funding organizations that support my clinical research work. And I would like to thank you again for your attention. I'm happy to take any questions. This is again my email and Twitter handle. Please feel free to reach out to me. Thank you so much. Okay, so there's a question basically from if there is a symptomatically, morphologically low risk but genetically high risk of MDS who is asymptomatic, do you initiate treatment? So again, this is, I think, a difficult question that requires some discussion with the patient. We certainly know that the IPSS and revised IPSS does not capture many patients who have higher risk disease, although they are currently being classified as lower risk. And this is why the molecular tools are being established. I think currently the standard of care is that if the counts are not requiring treatment, is to hold off, except in younger patients where you are trying to go for a cure. So if your goal is to try to go for a cure and allogenic bone marrow transplant, and if someone has excess blast or adverse molecular features, even if they are asymptomatic, I would consider treatment. But in older patients in whom cure you cannot achieve or too old for transplant, I think it's a matter of discussion with the patient whether to treat or not if they have no symptoms and their blood counts are good. Is the endpoint of treatment in MDS elimination of mutation on therapy or clinical improvement? Again, that's a very good question. MRD negativity is an evolving field. We are trying to better understand it in the context of MDS. There is much more data in AML. Currently, in MDS, clinically, we still aim for clinical improvement in the sense of complete remission. It's not as easy to get cytogenetic full responses or molecular responses like in AML because the bone marrow microenvironment is very diseased and sometimes there's very little residual hematopoiesis in to kind of come back to normal in many of those patients. So currently the goal is still clinical improvement and to try to go to transplant. Can we sequence HMA and VIN or are they to be given together? I think this is a very good question. I showed you data in the front line of the combo as well as adding VIN afterwards, and I think there is clinical activity in both settings. Ideally, you want to have randomized data, so we have a randomized trial in the front line setting. In the refractory setting, we don't have currently ongoing randomized studies, but I would say in patients who have HMA failure where you don't have options and many times they cannot get intensive chemo or go to transplant, and since VIN is out there, this might be something you can discuss with your patient. And but if you do it, you have to monitor them very well, give them prophylaxis for infections, transfuse them. It's something that I think requires a lot of close monitoring. Do you routinely do a bone marrow biopsy after first cycle to see patient in remission and treating with VIN-AZA? Correct. So we do it actually the same way we do it with AML, with the combo, is that at the end of the first cycle, we do a bone marrow biopsy around day 21 to day 28, because many patients, the blast count will go down. And in that situation, you probably could wait on the next cycle. So rather than starting on day 29 for week cycles, you could delay 1 or 2 weeks to allow for count recovery if the blast count is low, similar to what we do in AML patients. And if you don't have any count recovery by day 42 you resume, you could consider reducing the duration of venetoclax or reducing azacitidine or potentially go to transplant if the blasts are less than 5% and patient is a candidate. And I think this is the last question. Again, very happy to respond to any subsequent questions via Twitter or on my email. And thank you so much. And thank you so much for the International Academy for Clinical Hematology for inviting me today to share this presentation with you. Thank you so much. Bye-bye.